Let's talk about congenital diaphragmatic hernia. Let's be simple and as concise and to understand everything. What is congenital diaphragmatic hernia? It is a developmental defect in the diaphragm, allowing abdominal organs to herniate into the chest. For example, a hole in the anterior at the front and medially, like this, is called hernia of Morgagni. Something posterior in the back and laterally is called bogdalic hernia, which is the most common type. There is also the hiatus hernia. We're not going to be talking about it today. There's also something called eventration of the diaphragm. We'll talk about it in a second. Let's talk about the anterior Morgagni hernia. It usually happens retrosternal or parasternal, behind the sternum or next to it, most commonly on the right side. On the other hand, the bogdalic hernia is most commonly on the left side. If you would like making comparisons and stuff, you can do that. Cause: failure of fusion of the septum transversum. Happens usually 2 to 6% of all congenital diaphragmatic hernia cases. The contents is usually the colon, the omentum, or the liver. Symptoms: these kids are often asymptomatic, found on accident. Why? Because there's a hole, so leading to recurrent infections and respiratory distress. But as soon as you diagnose it, you need to treat it. Surgically repair it, right? How do you diagnose it? First of all, an X-ray will be good enough, CT to confirm. The bowel is located behind the sternum or parasternum. You reduce, you excise the sac, and you close. You suture the diaphragm to the posterior wall of the rectus sheath. Is pretty much how you treat this case. On the other hand, diaphragmatic eventration is not a real hernia, as a matter of fact, just the mesodermal defect, or the phrenic nerve is paralyzed or palsy. So there is an elevation of the diaphragm due to absent or weak muscle fibers. So if you think right now, I said weak or absent, well, what's the treatment? Is plication. You need to make the diaphragm stronger, right? Dome-shaped elevation, mild dyspnea, recurrent chest infections, asymptomatic. If you do an X-ray, you'll show a high hemidiaphragm, okay? Or an ultrasound will show reduced movements. Very easy. The treatment, as we said, the diaphragmatic plication, which also means like you try to strengthen the diaphragm, right? The redundant diaphragm. Okay. The bogdalic hernia, the most important part and pretty much the part where your whole exam will be about. The bogdalic hernia. Let's talk about the epidemiology. 1 in every 2,500 births or 4,000 births. Very common, like more common than you think. More commonly on the left side. Associated anomalies. Let's talk about anomalies. Cardiac defects. The most common associated anomaly is the cardiac defects. Also chromosomal anomalies, urotubal anomalies, and GI malrotation. Now let's talk about the pathophysiology. The diaphragm failed to fuse at the 10 weeks mark, which is usually the time for it to fuse. The hernia will lead to the abdominal viscera going into the thorax. And the developing lungs are now collapsed. Why are they collapsed? Because there is an intestine on them, there's a liver on them, there's a stomach on them. Primarily, it's the intestine. Sometimes there is a stomach herniation or liver herniation. Reduced pulmonary vasculature, which lead to harder time for the pulmonary vessels because they're now thickened and muscular, trying to compensate, leading to pulmonary hypertension. Pulmonary hypertension leads to eventually right to left shunt and hypoxemia. Also, there's liver herniation if it's on the right side. Usually, it's a very poor prognostic factor. The presentation. Use your common understanding. Now that the abdomen is empty pretty much and everything is in the chest will be distended. The abdomen will be scaphoid. It will be scaphoid, like the picture. There will be respiratory distress because of the pulmonary hypoplasia, leading to cyanosis, tachypnea, grunting, nasal flaring. The kid's muscles are now retracting, like intercostal, subcostal retractions, all these muscles. If there is hypoplasia on the affected side, or actually sometimes both sides, there will be decreased breath sounds, or absent breath sounds. The heart sounds are usually shifted because of the mediastinal shift that happened, right? And it will lead to displacement of the cardiac apex. Now that the intestine is in the chest, you might be able to hear bowel sounds in the chest. How do you diagnose? 2/3 of the cases are diagnosed prenatally or antenatally. You could do an ultrasound which will show polyhydramnios, visible bowel loops, and abdominal organs located in the thorax and the mediastinal shift present. Very easily diagnosed, to be honest. You could also do an MRI. Now let's talk about the MRI. The MRI will do two things. First of all, see if there's liver herniation. Two, will quantify the lung volumes, either seeing the total lung volume, and it will be decreased, or the lung head ratio. What would the lung head ratio do for me? It's an indicator for prognosis again. What is the prognosis here? First of all, if it's less than 1, if the head is bigger than the lung, that means there is severe hypoplasia, leading to poorer prognosis, right? How do I definitely diagnose and say 100%? You will do a postnatal x-ray. You will see air loops or air-filled loops in the chest and paucity of gas or cessation of gas, no gas in the abdomen, and the mediastinum is shifted to the other side. You'll also do an echocardiography to assess for pulmonary hypertension or to check for cardiac anomalies, which, as we said, the most common cardiac anomaly. You could also do other things, like for example, when you do X-ray, you need to check GIT for malrotation. You need to do ultrasound kidney to check for anomalies. There's polyhydramnios, and also ultrasound brain in case the hypoxia did a lot of damage, you know. And as we said, of course, the echo is the most important one. You'll also sometimes find no gastric air bubble. Why? Because now the gastric air bubble, the normal one, is now in the abdomen, right? And as we said, the shifted cardiac pulsations. Now, resuscitation is the most important step in the treatment, as a matter of fact, because this is not a surgical emergency, it's more of a medical one. This kid is now severely cyanosed and can't breathe, blah blah blah. What you do is you ventilate this patient and you give him a nasogastric tube. Early intubate, you have to intubate him. You don't give him back mask ventilation. Why? Because if you give him that air, you will fill out the stomach, you'll fill out the intestines, which is, well, they're in the chest now, very bad. The pulmonary hypertension is usually give the kid oxygen, nitric oxide, and vasopressors. If all these things fail, you do an ECMO, extracorporeal membrane oxygenation, as a rescue therapy. What is ECMO? ECMO is literally heart-lung bypass. That's all it is. It's a heart-lung bypass. There's also something called prenatal intervention if diagnosed antenatally. Fetal endoscopic tracheal occlusion. From its name, tracheal occlusion, you close up the trachea using endoluminal clips or a foam plug or a balloon. Leads to accumulation of the lung fluids. The lungs will start stretching and growing, and the pulmonary vessels start to develop and proliferate. And then before birth, you remove that balloon or that plug or whatever. Surgical repair. It's inevitable, but the kid needs to be cardiorespiratory stabilized, and there needs to be stabilization. What you do is you do a subcostal incision, laparotomy. You reduce the organs and close the sac or the defect. In stable infants, you could use something like thoracoscope or laparoscope. Right? The intestines now are returned to the abdomen, and the diaphragm is reconstructed. You close everything, and you close, and then you fix the diaphragm. How do you close? I'm saying close. How do you close? First of all, you need to do primary sutures. Primary suturing. You close it up, suture it up. If it's a small defect. If it's a big defect, you could use a synthetic patch or a biologic material to close that if it's big. But they are more commonly associated with anomalies. Sorry, not anomalies, recurrence. 20% more recurrence rate. Survival is 70% overall, drops to 50 if the ECMO was used, the heart-lung bypass was used. Usually it's a good prognosis if you're discharged to home. Sometimes there's complications like lung disease chronically and pulmonary hypertension, GERD, and ECMO could risk neurocognitive deficit. As you said, 20% recurrence if patch is used, right? Usually you do a multidisciplinary team approach for treatment, a pulmonologist or a chest doctor, a GI internalist, nutritionalist, and a cardiologist, and a developmental doctor, usually neuro, for optimal outcomes. Now we've talked about everything pretty much. We need to talk about the poor prognosis. Cardiac anomalies are very poor prognosis, and they're also the most common one. Right-sided, because now on the right side, there is more commonly liver herniation, bad prognosis. Lung head ratio less than 1, which are detected with the fetal MRI prenatally, mostly. Poor prognosis. Okay, we are done here. But you could also try to, before we finish, differential diagnosis, esophageal atresia, congenital heart disease, or agenesis of the lung, whatever. Anything that leads to lung agenesis or pulmonary hyperplasia. Thank you.